Okay, good morning everyone, and thank you for tuning in to Grand Rounds this morning. Our two speakers today are Dr. Hannah Fisher and Dr. Erica Stevens. Dr. Hannah Fisher completed her training in neonatology at the University of Louisville and joined faculty as an assistant professor in 2015. She has completed the Intermediate Improvement Science Series and Advanced Improvement Methods courses through Cincinnati Children's Hospital and currently serves in the role of Director of Quality Improvement and Safety for the Division of Neonatology. She's been involved with or led many quality improvement projects locally and is inspired by the improvement and outcomes that can be achieved. She aspires to teach others to improve their healthcare systems and has developed the Neonatal Fellows Quality Improvement Curriculum to further this goal. Dr. Fisher's work has been recognized by her peers, and she received the Pediatrics Outstanding Performance Award for her quality improvement work from the Department of Pediatrics in 2019. Dr. Fisher was promoted to Associate Professor in 2021. Dr. Erica Stevens is an Evansville, Indiana native, where she completed her undergraduate degree at the University of Southern Indiana. She then attended medical school at the Indiana University School of Medicine and completed pediatrics residency at the University of Louisville in 2017. Following residency, she completed her pediatric pulmonology fellowship at the Children's Hospital of Pittsburgh of UPMC, while also obtaining her Master of Public Health from the University of Pittsburgh. Dr. Stevens joined the Division of Pulmonology, Allergy, and Immunology at Norton Children's in August 2020 and is excited to be back in Louisville. In addition to her clinical role, she is an assistant professor of pediatrics at the University of Louisville School of Medicine, serves on the Resident Education and Working Environment Committee, and is the Associate Director of Pediatric Pulmonary Fellowship. Her clinical and research interests include asthma, cystic fibrosis, sickle cell disease, and bronchopulmonary dysplasia, very relevant to today's talk. So without further ado, I'll hand it over to Dr. Stevens and Dr. Fisher. The CME code is in the chat at the top right of your screen. The number is 130408.
Okay, excellent. Can you hear me okay and see our slides?
Email her, okay?
Yes.
Okay, excellent. So good morning, everyone, and thank you so much for attending our talk. Hannah and I are both very excited to be collaborating both on this talk and also on hopefully future endeavors in our own institution, which we'll touch more on later on in the talk. So today we'll be talking about bronchopulmonary dysplasia. And first we're going to talk about some of the associated definitions, the underlying pathophysiology, epidemiology, BPD prevention, as well as some of the management strategies of BPD. Next, we'll touch on some of the long-term outcomes, as well as the importance of use of a multidisciplinary approach in this patient population. So just to provide a very brief intro, President John F. Kennedy and the First Lady made headlines now almost 60 years ago, back in 1963, when Jackie gave birth to their son Patrick at only 34.5 weeks gestation. He was born weighing in at only 4 pounds, 10.5 ounces, and unfortunately later succumbed to hyaline membrane disease, or what's now known as respiratory distress syndrome, at only 39 hours of life. Although they had performed everything that they could at the time for the baby, treatment was very limited at that time and consisted of normalizing blood gases as much as possible and providing hyperbaric oxygen therapy, which was a revolutionary treatment at that time. So although this was obviously a very tragic event that occurred due to the publicity of this family, it did provide a spotlight on a big deficit that was present in the medical field and helped to spur advancement in medical technology and research and effectively the development of neonatal medicine. BPD was first described in 1967 by William Northway, who was a pediatric radiologist by training, and colleagues as the complications of hyaline membrane disease, which again is now known as respiratory distress syndrome. So they published this retrospective study covering 32 infants with severe respiratory distress syndrome that unfortunately had a very high associated mortality rate of 59%. The infants were treated with mechanical ventilation in high FiO2, and the authors described 4 distinct stages of pulmonary disease, from evolution of more acute disease to chronic lung disease by way of clinical symptoms with associated radiographic findings and histologic findings. So regarding the specific definitions, the classic definition has essentially involved the need for supplemental oxygen at 28 days of life, as well as radiographic evidence of chronic lung disease. So this was based upon Northway's findings. And the definition of BPD has certainly evolved over time. So following this initial definition in 2001, the NICHD then proposed an updated version after a consensus conference was held to better categorize by disease severity. So with this newer definition, they further classified BPD as mild, moderate, or severe based upon the amount of supplemental oxygen needs, as well as mode of support at 36 weeks post-menstrual age. So although this 2001 definition was improved, it didn't account obviously for interventions that were developed after 2001, such as use of respiratory support without supplemental oxygen or early lethal BPD. And some of the studies suggested that this definition was pretty lacking as far as sensitivity and specificity to predict more long-term pulmonary morbidity. And so in this study, with the data presented here, as you can see, nearly 1/3 of patients that did not meet criteria for BPD still had pulmonary morbidity, while over 50% of those that did meet criteria for severe BPD did not have any pulmonary morbidity. So obviously this still is an imperfect updated version. So then in 2016, another updated definition was proposed that classified severity by grades 1 through 3. And then this definition also accounted for category 3A to denote early lethal BPD. And the NICHD continued to still, work on this evolution of the definition. So in 2019, they attempted to utilize a more evidence-based approach to diagnosing BPD. And so in this prospective study, they found that the best definition was based upon mode of respiratory support at 36 weeks post-menstrual age, regardless of supplemental oxygen use. And so this is the most up-to-date version that we have so far. But essentially, there's still no perfect definition or classification scheme for BPD. And as you can imagine, with so many different proposed definitions at different time points, it's very difficult to perform research studies and to compare data from different time periods. Next, we will talk about lung development and underlying pathophysiology of BPD. So in order to best understand the underlying pathophysiology related to BPD, it's important to have a basic understanding of lung development and embryology. So the stages of development are comprised of 5 main periods of development that are overlapping, as different sources in the literature define different timeline ranges, and much of our understanding is also based upon animal models. So the first stage or period is known as the embryonic period and occurs from 3 to 6 weeks post-menstrual age. The lung at that time is derived from a ventral outpouching of the primitive foregut. And the primary bronchi then elongate and divide into 2 main stem bronchi. The main pulmonary artery also arises from the 6th pharyngeal arch during this phase. The next stage is the pseudoglandular stage, which occurs from 6 to 16 weeks post-menstrual age, and by the end of this period, all of the major conducting airways are formed, including the terminal bronchioles. Next, we have the canalicular stage, which occurs from 16 to 26 weeks post-menstrual age, and during this time, there is development of the respiratory bronchioles, which is very important, and also very importantly, there's this rich vascular supply that together with the respiratory bronchioles forms a primitive blood-air barrier that is absolutely necessary for gas exchange. And by the end of this period, the terminal sacs form. Next, we have the saccular stage, which occurs from 26 to 36 weeks post-menstrual age. And during this time, there's significant capillary proliferation and thinning of the epithelium that allows for much more efficient gas exchange, and epithelial cells also begin to differentiate. Another very important aspect of this period is the maturation of the surfactant system, which occurs at approximately 35 weeks gestation. Last, we have the alveolarization stage, which begins at around 36 weeks postmenstrual age and lasts into early adulthood, approximately till 21 years of age. And during this time, secondary septa form on the walls of the saccules and grow into the lumen, forming the walls of true alveoli. So the bulk or classic alveolarization ends at approximately 3 years of life, but newer data in animals and humans suggests that as long as the lungs are growing, there's continued alveolarization into early adulthood. This is just a nice diagram that provides a good visual of the developmental stages that we talked about, including the airways, and on the right, the development of the pulmonary vasculature, which is laid out by stage of lung development. So moving on to pathophysiology, despite the previously discussed definitions, BPD is probably actually best considered a syndrome, given there's not a single etiology and clinical courses and outcomes are variable. So the pathophysiology of BPD is very complex and multifactorial in nature. And this diagram shows several antenatal, natal, and postnatal factors or insults that lead to disruptions in vascular and alveolar development that can in turn lead to BPD over time. This diagram again demonstrates the developmental stages and further subdivides BPD into this quote new and quote old BPD by gestational age, with an emphasis on what specific exposures may lead to structural injury and eventually BPD. So first we'll talk a bit more about old BPD. So old BPD occurred in more of the pre-surfactant era and is much less commonly seen now, and it is both radiographically and histologically very different from newer BPD. In old BPD, there's this presence of alternating atelectasis and hyperinflation, which can be seen in the radiograph on the left. And there's essentially this fibroproliferation that occurs with associated airway epithelial changes, including squamous metaplasia and airway smooth muscle hyperplasia. The alveoli are overdistended in some areas, collapsed in some areas, and may even be obliterated in some areas of the lung. So with decreased alveolarization, there's also decreased surface area and significant remodeling of the pulmonary arteries as well, which can in some cases lead to pulmonary hypertension. And so these changes are most often occur as a result of lack of surfactant therapy, along with oxidative injury and volume-associated lung injury from mechanical ventilation. So this is what would have been seen earlier with Northway's time in the 60s. So next we will talk a bit more about newer BPD. So new BPD is closely associated with extreme prematurity. And as we discussed previously, the fetal lung at about 23 to 24 weeks gestation is generally at the late canalicular or early saccular stage of growth. And this is characterized by immature airway structure as seen on the left, with undifferentiated epithelial cells, a paucity of capillaries, which are also dysmorphic, and fewer and larger, more simplified alveoli. And all of this leads to reduced surface area for gas exchange. Given all of that, there is much less regional heterogeneity that was previously seen in older BPD. And as you can see in the chest X-ray on the right, there's more of this granular appearance rather than the heterogeneous areas of atelectasis and hyperinflation that we saw in old BPD. So premature birth itself, with arrest of pulmonary development and possible injury from other comorbidities in the premature infant, therefore have very profound implications for the risk of BPD. So next, I'll turn it over to Hannah, who will discuss more of the epidemiology of BPD.
Thank you. All right. So epidemiology of BPD. BPD is very common in extremely preterm infants, and it affects approximately 10 to 15,000 infants per year in the U.S. alone. As you may remember, there's an inverse relationship with birth weight and gestational age, and 97% of infants with BPD have a birth weight less than 1,250 grams. And despite improving technology, the incidence of BPD has not decreased, and it may actually be increasing as the survival of these extremely preterm infants is also increasing. At Norton Children's NICU, we submit data regarding our premature infants to an international database, the Vermont-Oxford Network. Through this database, we're able to compare our outcomes to centers all over the world and follow trends over time and work to improve morbidity and mortality for our infants. Since 2005, the Vermont-Oxford Network has seen significant declines in the rates of all major morbidities except chronic lung disease. The cause of this is multifactorial. The VON has identified improving BPD as the next great challenge for network centers. So let's take a look at our own data of respiratory outcomes of premature infants. The following graphs are run charts comparing Norton Children's Hospital Level 4 NICU with other like centers over time from 2011 to 2020. The gray shaded areas represent the interquartile range, while the blue line and dots are our center's data. The outcome being assessed is listed at the top, and the arrow depicts the desired direction. The Vermont-Oxford Network uses the term chronic lung disease for BPD and defines it as a premature infant requiring oxygen at greater than 21% at 36 weeks corrected age. Our chronic lung disease rates have remained steady at about 30% or so over the last 5 years, which is at the 50th percentile for like centers within the network. Over 75% of our very low birth weight infants are ventilated at some time during their NICU admission, and over 20% are ventilated greater than 28 days. This is greater than the majority of like centers within VON. Our use of steroids for management of chronic lung disease in premature infants is greater than the majority of like centers within VON and has risen over the last 3 years, as has the network's use of steroids in general. We'll talk about this trend a little bit more later in this presentation. Home oxygen use correlates with BPD severity. Over the last 5 years, we have had 25 to 30 patients or so discharged home on oxygen per year, and that number is rising. Now let's take a look at some of the risk factors leading to BPD and what we can do to prevent it. We can classify risk factors for BPD into genetic, prenatal, and postnatal factors. Twin studies have suggested that there is a genetic component to susceptibility to BPD, independent of other factors, including birth weight and gestational age. There are many genes involved in normal lung growth and development, and abnormalities in these genes may contribute to the development and the severity of BPD. Other potential genetic factors include male sex and white or non-Black race. Prenatal factors include prematurity, as discussed, and other complications during gestation that lead to inflammation and poor growth, such as maternal smoking, preeclampsia, and chorioamnionitis, to name a few. And postnatally, infants with RDS, PDA, higher fluid intakes, and infections have higher rates of BPD. Some studies show an association with earlier parenteral lipids and light-exposed parenteral nutrition. And lung injury due to mechanical ventilation and oxygen are also known contributors. There have been many recent studies looking at race and outcomes in the neonatal ICU. The Prematurity and Respiratory Outcome Program, or PROP, was a large multi-center study following a cohort of very low birth weight infants throughout the first year of life and assessed respiratory outcomes. Enrolled families reported their race, and a subset of those families then had DNA ancestry performed to validate their responses. The study found that despite having more risk factors for developing BPD, Black infants had lower rates of a diagnosis of BPD at discharge compared to white infants. This was consistent across gestational ages and across centers. These findings are also consistent with many other studies. The study did not have a clear causation to these findings. They postulated that exposures during gestation may facilitate faster maturation of lungs and surfactant production. Stratifying our BPD data by race for Norton Children's NICU for the years 2015 to 2020, we see about equal rates of BPD across Black, Hispanic, and white races. The other races listed had a low N and therefore are not valid for comparison. However, lower BPD rates may provide false reassurance about respiratory outcomes in Black children, as in the PROP trial, they had worse long-term pulmonary morbidity. Parents of enrolled infants in the PROP study were surveyed at discharge 3, 6, 9, and 12 months of age for post-prematurity respiratory disease. Factors that were assessed included hospitalization for respiratory indications, home respiratory support, respiratory medication use, and respiratory symptoms. Post-prematurity respiratory disease was then classified as severe, moderate to mild, and minimal to none. And despite having lower BPD rates at discharge, Black infants had increased risk of post-prematurity respiratory disease. BPD is an independent predictor of childhood pulmonary disease, but other factors affecting Black infants more than white may be contributing to this outcome. The authors postulate these could include environmental factors, less breast milk exposure, increased number and severity of viral illnesses, and other socioeconomic factors. So moving on to prevention. As we've discussed, BPD is caused by lung injury to a premature developing lung and is multifactorial. Preventing BPD has been challenging. Therapies such as antenatal steroids and surfactants have reduced the incidence of respiratory distress syndrome and mortality, but have not reduced the incidence of BPD. As we will discuss later, BPD leads to significant and long-term pulmonary and neurodevelopmental morbidity. Therefore, considerable research has been put into developing ways to prevent BPD. We employ many practices to prevent BPD and protect premature infants from lung injury, a few of which have good data for support and others with conflicting data. But even our best therapies only lead to a modest reduction in BPD in the 7 to 11% range. There are 3 therapies with the best evidence for use to reduce BPD. Vitamin A is a fat-soluble retinoid compound that promotes cell differentiation and growth, particularly after lung injury. Preterm infants have low vitamin A levels at birth, and supplementation has been shown to modestly reduce rates of BPD. Vitamin A is well tolerated and relatively inexpensive. Unfortunately, it has had periods of unavailability in recent years and has fallen away as a therapy in many centers. Caffeine is a methylxanthine and is used to treat apnea of prematurity. In the CAP trial, the secondary outcome of BPD was reduced in the group of infants receiving caffeine. The cause is uncertain, but caffeine remains a cornerstone of management for preterm infants. Steroids reduce inflammation and improve surfactant function and are used to prevent or treat infants at risk for BPD. And we'll talk a little more about their use in the upcoming slides. There are many practices that have mixed results in the literature, but likely contribute to decreasing lung injury and are therefore practiced in the NICU. These include providing non-invasive respiratory support, such as CPAP, gentle ventilation and permissive hypercapnia if invasive ventilation is needed, and judicious fluid administration. Inhaled corticosteroids have theoretical benefit in reducing inflammation that may contribute to BPD, but to date have not been shown to definitively decrease BPD incidence in 12 randomized controlled trials. There are a few practices that have been disproven as management strategies for preventing BPD. Though we know that having a hemodynamically significant PDA is associated with developing BPD, prophylactic closure of the PDA does not lead to a decrease in BPD rates. Inhaled nitric oxide has a theoretical basis to prevent BPD by enhancing alveolar development and angiogenesis in animal models. And initial trials displayed conflicting results, but were heterogeneous in their use of inhaled nitric oxide. Later, larger meta-analyses and a large individualized patient-level meta-analysis did not demonstrate an effect on BPD with prophylactic inhaled nitric oxide. So currently, the AAP and NIH recommend against using inhaled nitric oxide for this purpose. Preterm infants have a limited antioxidant capacity that leads to increased damage to tissue by free radicals. However, studies evaluating anti-inflammatory supplements such as superoxide dismutase and glutathione have not demonstrated improvements in BPD and have concerning safety profiles in preterm infants. As I stated before, steroids reduce inflammation and improve surfactant function, and they've been used for decades to prevent or treat infants at risk for BPD. However, their use has been tempered by adverse outcomes. And ultimately, the goal should be to use the right steroid at the right time and the right dose to minimize adverse effects and optimize respiratory outcomes. It's important to look at the history and trajectory of steroid use in the NICU over time to understand how and why their use has evolved. Beginning in the 1980s, small studies and anecdotal experience showed short-term improvement in respiratory status in preterm infants treated with steroids. Dexamethasone, which is a glucocorticoid, was primarily used in high doses for long courses extending over weeks. The hope was to improve respiratory and developmental outcomes by facilitating earlier extubation and less BPD, and these practices became widespread. However, randomized controlled trials that included long-term neurodevelopmental outcomes didn't become available until the mid-90s. Trials of early steroid treatment started within 7 days demonstrated an improvement in the incidence of BPD, but also were found to have a significant increase in the risk of cerebral palsy and poorer neurodevelopmental outcomes, particularly motor outcomes. Trials of late steroid treatment after 7 days also showed benefit in reducing BPD and were inconsistent in their demonstration of the neurodevelopmental impairment. Dexamethasone was the steroid primarily utilized in most of these studies, which is long-acting and binds to glucocorticoid receptors in the brain, potentially decreasing neurogenesis and inducing apoptosis. Based on the concern for cerebral palsy and neurodevelopmental impairment in steroid-treated infants, there was a precipitous decrease in the use of steroids throughout the late 90s. In 2002, the AAP Committee of Fetus and Newborn published a statement recommending against the routine use of dexamethasone for the prevention or treatment of BPD. They also recommended any clinical trials of steroids in neonates include long-term neurodevelopmental assessment. This study evaluated steroid use in the Vermont-Oxford Network and Neonatal Institute of Child Health and Human Development networks from 1990 to 2004. And you can see the rise in use of steroids throughout the early 90s that peaked in 1997 to 1998, then precipitously declined around the time long-term studies demonstrating worse neurodevelopmental outcomes became available. More recent trials have targeted alternative steroid courses, such as inhaled corticosteroids and hydrocortisone. Hydrocortisone primarily binds to mineralocorticoid receptors, and randomized controlled trials has shown a decrease in BPD incidence with early treatment. Hydrocortisone use has been associated with increased risk of intestinal perforation, but does not seem to demonstrate association with adverse neurodevelopmental outcomes to this point. It's also possible that there are a subset of infants that would benefit from steroid administration with dexamethasone despite the risks. Targeting steroid use to this population and limiting it in lower risk populations may actually improve both pulmonary and neurodevelopmental outcomes. And Doyle et al. Investigated this theory in a meta-regression analysis of 20 randomized controlled trials of steroid use for prevention or treatment of BPD. They found the risk of adverse neurodevelopmental outcome was inversely related to BPD risk. BPD is an independent risk factor for neurodevelopmental impairment, and as the BPD risk increased above 65%, the risk of cerebral palsy or death was reduced, leading to a more favorable side effect profile for dexamethasone use in this population of high-risk infants. And in the last 5 to 10 years, there has been an increase in steroid use, possibly due to the increased use of hydrocortisone and targeted dexamethasone use as just discussed. And that brings us to what may be in our future. In the past, neonatologists have had to balance the need for invasive surfactant administration in preterm infants with the desire to decrease the inflammatory cascade and prevent intubation and mechanical ventilation. Large randomized controlled trials showed that early surfactant was beneficial, but trials of non-invasive ventilatory support with subsequent selective intubation had similar outcomes. In an ideal world, both surfactant administration and non-invasive respiratory support would be provided. This has led to the development of minimally invasive ways to provide surfactant, either through intubation with a thin catheter or aerosolized and inhaled through an LMA or other interface. Randomized controlled trials are promising for reducing the need for intubation and BPD use using these methods. So with limited effective individual strategies to prevent BPD, using quality improvement methods to optimize care has become an area of interest for BPD prevention. Significant variation in risk-adjusted rates of BPD amongst centers exists, and is thought to be due to variability in practices. So understanding what makes high-performing centers successful and standardizing and spreading those interventions may lead to more widespread decrease in BPD rates. The Vermont-Oxford Network has led some of the first quality improvement collaboratives targeting BPD as an outcome with some success. In the Breath Savers Collaborative from 2001 to 2003, 19 centers participated, 12 with BPD rates that were higher than the Vaughan average. Participating centers identified potentially better practices based on the best evidence, expert opinion, and group discussion, and implemented a variable number of those in their center. There was considerable variation in BPD rates among centers ranging from 13 to 66%. The collaborative as a whole was able to improve survival without BPD from 53 to 63%, and most centers saw a decrease in their BPD rates. Those that had increased in their rates over this time were centers that were already very high performing and were well below the Vaughan average. Centers also saw a concomitant decrease in the use of ventilation, postnatal steroids, and supplemental oxygen use, and an increase in CPAP and early surfactant. However, not all QI projects targeting BPD have had success. In a systematic review assessing the success of QI projects targeting BPD, the 3 Vaughan initiatives showed variable degrees of decrease in the outcome of BPD. But the NICHD Neonatal Research Network trial of QI from 2001 to 2004, in which they randomized centers to performing a BPD QI project and then to controls, found no difference in the rate of BPD or BPD severity between groups. A similar study design in the Canadian Neonatal Network showed a trend toward decreased BPD, but was not statistically significant. And the California Perinatal Quality Collaborative found that their centers participating in a collaborative to decrease BPD had success, but not single center NICUs performing their own QI project. This heterogeneity in outcomes speaks to the difficulty in changing practices and affecting an outcome such as BPD. One of the most successful QI projects was published this year. This project was performed in a level 3 NICU in the Kaiser Permanente network in California. They targeted very low birth weight infants and had high rates of infants being inborn and receiving prenatal care. They developed a BPD prevention bundle with a BPD roadmap of best practices. This included nothing novel or new. It optimized the things that we already do every day in the NICU. These things included delivery room CPAP, if the baby had to be intubated, providing early surfactant and using volume ventilation with high frequency as a rescue, providing extubation criteria and respiratory support protocols, providing breast milk and optimizing nutrition for good growth, using medications such as caffeine, vitamin A, and early inhaled steroids, standardizing their steroid pathways, and using conservative PDA management strategies, and limiting antibiotic use and preventing infections. This group showed a significant decrease in BPD rates from 31% down to 1.6%, which has been sustained over the last 4 to 5 years. They used a traditional definition of chronic lung disease of oxygen at 36 weeks for this graph, but they also showed the same degree of improvement using a severity-based definition. And interestingly, their rates of ventilation did not change during this period. The authors attribute their success to creating a system of care and a change in culture leading to BPD prevention rather than an individual intervention. It will be interesting to see if this degree of reduction can be replicated in other units. So to summarize, there are few truly evidence-based practices to reduce BPD with only modest reductions. Therefore, optimizing best practices as a whole may contribute to reducing BPD incidence. And it remains to be seen if implementing newer treatments to minimize intubation while providing surfactant will continue to improve BPD rates. I'll turn it back over to Erica to talk about treatment and management.
Excellent. So moving on, although I could spend an entire talk on any single treatment of BPD, I'm going to try my best to summarize the main treatments utilized because this isn't the focus of our talk today. So the mainstay of therapy for BPD is, of course, to provide respiratory support by means of supplemental oxygen or positive pressure ventilation if needed, which we'll talk about more in depth a bit on the next slide. Nutrition is also a very important aspect of BPD care and must be optimized. As we previously discussed, alveolarization continues so long as the lungs are growing, and lung growth is largely dependent upon optimized nutrition. So in general, nutritional management consists of high caloric intake while limiting total fluid intake, which is the next point on the slide. Next, we'll talk about diuretics, which are one of the most commonly used class of medications in management of established BPD. So infants with BPD are prone to interstitial pulmonary edema related to increased capillary permeability, which may be related to volutrauma, barotrauma, or fluid overload. Studies have shown improvement in lung mechanics with improvements in respiratory scores and decreased FiO2 with use of diuretics compared to placebo. However, the literature does not suggest any decrease in duration of supplemental oxygen with diuretic use. As Hannah has previously discussed, corticosteroids is kind of an ongoing hot topic as far as BPD. And use of inhaled corticosteroids in early BPD improves pulmonary function, gas exchange, and wheezing, but later use has not been associated with improved lung function in BPD. Some animal models show decreased airway inflammation and edema, stabilization of capillary leakage, and possibly augmentation of beta receptor activity, which may lead to decreases in lung fibrosis. Inhaled corticosteroids are also often prescribed in patients with recurrent wheezing in BPD with viral respiratory infections. Studies, however, do show mixed data. One double-blind placebo trial with Flovent showed no significant difference in patients with established BPD regarding duration of supplemental oxygen use, respiratory illnesses, or rehospitalizations. And then moving on to just very briefly about systemic steroids, there's no clear indication for use of prolonged systemic steroids in established BPD. And then lastly, touching on pulmonary hypertension management, approximately 21 to 42%, that's a wide range, I realize, of infants with BPD have pulmonary vascular disease, which should definitely be screened for. The best initial strategy with pulmonary hypertension related to BPD is to treat the underlying cause and investigate any further possible exacerbating factors, including reflux, airway malacia, bronchospasm, etc. And despite the use of pulmonary vasodilator therapy for the treatment of pulmonary hypertension and BPD, data demonstrating efficacy extremely limited. So the use of these agents should only follow thorough diagnostic evaluations and aggressive management of the underlying disease. Inhaled nitric oxide and sildenafil are the most commonly used pulmonary vasodilators in BPD with pulmonary hypertension, but endothelin receptor antagonists and calcium channel blockers are also sometimes used. And touching a little bit more on positive pressure ventilation, the ventilation strategies in the acute phase of respiratory distress syndrome differ significantly compared to established BPD, given differing lung mechanics, which may be related to presence of lung heterogeneity, lung compliance issues, airway resistance, which can be increased, and differing time constants in different parts of the lung. And I could spend an entire talk on the debate about oxygen saturation targets, but there's really no optimal oxygen saturation target in neonates in general, but there's certainly also a lack of data to suggest a specific oxygen saturation target in BPD specifically. But the BPD Collaborative Network recommends a goal saturation of 92 to 95%, which is also consistent with what is recommended in infants with pulmonary hypertension. Hannah had briefly touched on permissive hypercapnia, which is often utilized, but the literature actually fails to provide any significant data to demonstrate long-term impact of permissive hypercapnia in BPD, particularly in severe BPD. But given established BPD, frequent blood gases may be less useful in this patient population. And then lastly, the main goal of positive pressure ventilation is to provide adequate respiratory support to allow for adequate growth and development. And of course, this can be provided non-invasively or invasively via endotracheal tube or tracheostomy. And long-term ventilation should be considered in infants with severe BPD who are not growing or developing well, with possibly slower weans over time. Next, we will move on to outcomes. So as you can imagine, BPD has long-lasting consequences in these premature infants that extend far beyond discharge from the NICU. So we're going to talk about some of those today. So first, we'll touch on lung function. So when examining lung function, it is important to consider an individual's lung function trajectory far beyond that in childhood. So this is an excellent diagram demonstrating that lung function increases over time following birth, reaching a peak in early adulthood. However, beyond that peak, even healthy individuals with no parenchymal lung disease have physiologic declines in lung function over time, which can be seen by the blue line in the figure. Factors that may affect the trajectory of long-term lung function may include genetics, intrauterine growth restriction, as well as exposure to maternal smoking in utero is associated with lower lung function. But the largest factor that's likely associated with lower lung function is prematurity and its sequelae. The red dotted line in the diagram represents a lower initial lung function in premature infants that reaches a much lower peak in adulthood with an even more rapid decline thereafter, which is of course concerning for development of COPD later in life. Premature birth thus has a very profound effect on lung function because premature infants, as we've discussed, are born during a critical window of rapid lung development and then continue their development in the extrauterine environment. Studies in healthy preterm preterm infants without BPD consistently demonstrate that this population does often have lung function abnormalities, with abnormalities seen in compliance, resistance, decreased forced expiratory flows, as well as decreased lung volumes. When examining the data of lung function in infants with BPD, we find that lung function does tend to track over time when measured at different time points. While compliance is typically reduced and resistance is increased, these improve over time during the first 2 years of life. Again, lung volumes are low, but FRC tends to increase over time, but the percentile remains low, which suggests that lung function does track longitudinally. Forced expiratory flows remain decreased into childhood and adulthood, suggesting persistent airflow limitation, again increasing the risk for COPD later in life. And there have been 3 phenotypes described that are associated with severe BPD, which include obstructive, restrictive defects, or mixed obstructive restrictive defects. But we must keep in mind that comparison of these studies are in general pretty challenged by the lack of a single PFT technique that can be applied throughout an individual's lifetime, as well as the evolving definition of BPD in different eras of study. So there are very few studies comparing healthy preterm lung function to lung function of those with BPD. And so to briefly summarize, those with BPD had lower lung function compared to age-matched controls longitudinally, which tracked over time when measured at different time points. And additionally, the effect of BPD on lung function appeared to be separate from the effects of prematurity on lung function. Next, we'll talk about some of these phenotypes that have been described in adults that had underlying BPD. So the first is more of this asthma-like syndrome. And so these patients present with similar symptoms to asthma. However, they may have poor symptomatic response to bronchodilators, which may be related to more of a fixed airway narrowing rather than reactive. And they may also have presence of bronchomalacia, both of which can certainly exacerbate symptomatic wheezing. And so while children may have good response to bronchodilators and ICS, they may lose responsiveness over time. And they found in these patients that they tend to have normal or low exhaled nitric oxide, which is less suggestive of eosinophilic inflammation that is seen in more classic Th2 type asthma. We've touched on this several times, but of course, there is concern for emphysema or COPD development. And so they have dyspnea on exertion, diminished exercise capacity, and wheezing, along with decreased lung function. And emphysema is typically centrilobular in nature and is more strongly associated with infants who had more of the older type BPD. And then last, we'll touch on this pulmonary hypertension phenotype. And so there are some proposed contributors to the development of pulmonary hypertension in BPD, which include abnormal developmental patterns in regard to the pulmonary vasculature. And so this poorly developed pulmonary vascular bed is thought to result in this fixed element of increased pulmonary vascular resistance. And studies in animal models suggest that presence of pulmonary hypertension may actually inhibit angiogenesis and alveolarization in the developing lung, which is obviously not optimal in BPD. And it is also very important to recognize that although we have all of this data, much of the long-term follow-up came from premature infants who survived before the introduction of interventions such as antenatal steroids, surfactant, improved nutrition, and less invasive tour support. And so it may not represent exactly what happens with the more recent survivors of extreme prematurity. So next I'll hand it over to Hannah for more cognitive and neurodevelopmental outcomes.
Thank you. So as we stated before, BPD in and of itself is an independent risk factor for neurodevelopmental impairment and cognitive delays. BPD is strongly associated with developmental deficits in children born preterm. And preterm infants with BPD have recurrent episodes of hypoxia, hypercapnia, and respiratory acidosis, which may predispose them to hypoxic-related brain injury. In addition, postnatal corticosteroids that we use to prevent or treat BPD are a risk factor for neurodevelopmental deficits. Differences in scores persist when adjusting for brain injury and prematurity, which is what makes BPD an independent risk factor for NDIs. Infants with BPD have an increased need for early intervention services, including physical, occupational, and speech therapies. These neurodevelopmental impairments may persist into early childhood and school age. Children with BPD perform worse on testing for general intelligence, reading, mathematics, motor performance, memory, and attention. These impairments in performance extend to testing at 8 years of age. BPD can also have long-lasting effects on the entire family. On one hand, getting to bring a complex preterm child home from the hospital can be a positive milestone. However, in studies, caregivers of children with BPD report a lower total healthcare-related quality of life. This can be caused by caregiver fatigue, social isolation, marital conflict, financial stress, anxiety about the child's care, and balancing work and life. Studies suggest that these healthcare quality scores improve over time as the child grows and their symptoms of BPD regress. There's also a financial burden associated with care for premature infants with BPD that extends beyond the NICU stay. In this study, infants with BPD had longer lengths of stays and higher costs associated with their initial NICU admission. They had increased rates of rehospitalization during the first year of life, with higher costs compared to admissions of premature infants without a diagnosis of BPD. A Canadian study simulated the lifetime cost of caring for infants with BPD, including their comorbidities. They estimated lifetime costs to be on average 700,000 Canadian dollars, only 28% of which is incurred in the first year. Ongoing costs include lifetime management for asthma and neurodevelopmental impairment, which declined over time. Cost was associated with the severity of BPD and the expected complications and morbidities. So in summary, infants with BPD are at higher risk for poorer pulmonary and neurodevelopmental outcomes and increased costs associated with managing these issues over time. Families of infants require ongoing support in caring for their child with a history of BPD.
So for the remainder of our talk, we're going to focus on the need for a multidisciplinary approach in infants with BPD. So according to expert consensus guidelines, a multidisciplinary approach is strongly recommended. There are some direct quotes that I've placed here from the European expert consensus guidelines. So essentially the authors highlighted the need for multidisciplinary care that extends from the neonatal period into adulthood to improve long-term outcomes, as well as a need for further research into interdisciplinary BPD care. Likewise, the 2016 NICHD workshop executive summary provides similar recommendations. The summary stresses the need for multidisciplinary research and clinical teams with involvement of multiple subspecialists. Shepherd and colleagues published a study in 2012 looking at outcomes after implementing a comprehensive center for BPD. The Comprehensive Center for BPD consisted of an interdisciplinary team as listed on this slide. The main goals of this intervention were to improve evidence-based care and empower families to actively participate in care. Infants were identified between 28 to 56 days of life as highly likely to suffer from BPD and were entered into the CCBPD. After establishing care, the team would meet on a routine basis to identify goals of care, including discharge requirements. And prior to discharge, the families also met with the outpatient team to provide a more smooth transition to outpatient care. Following implementation of the BPD Center, the authors found decreased readmission rates in this population as seen on the left, and they also examined neurodevelopmental outcomes in subgroup analyses. They found that compared to national data from the NICHD research group, rates of Bayley cognitive and or language scores, as well as motor scores of less than 70 were significantly lower for the CCBPD infants with both moderate and severe BPD. Another study was from McKinney and colleagues who created a severe BPD interdisciplinary team at Women and Infants Hospital in Rhode Island in 2011. And patients were referred to this program based upon meeting any of the following criteria at 36 weeks postmenstrual age, including evidence of pulmonary hypertension, FiO2 need of 30% or greater, use of positive pressure ventilation, or high flow nasal cannula greater than 2 liters per minute. The goals of this team were to improve overall management of severe BPD, standardize some of their treatments, screen and treat for pulmonary hypertension, and essentially provide a smooth transition from inpatient to outpatient care. The BPD team would round unidentified patients twice a month with the neonatology team. The authors then followed up with a publication looking at outcome measures resulting from the implementation of the BPD team. So in this study, they found a significant reduction in mean length of stay in the NICU, as well as significantly improved weight Z-scores at discharge, and fewer infants were actually discharged on supplemental oxygen following implementation of the BPD team. This is an interesting study from Yi and colleagues that examined oxygen weaning following discharge in infants with BPD. This study consisted of 420 infants with physician-diagnosed BPD, 154 of which were discharged on supplemental oxygen. So the figure on the right demonstrates the location and method of supplemental oxygen weaning following discharge. While the vast majority of patients were weaned outpatient by means of sleep study data, shockingly and probably dangerously, nearly 1/3 of the infants' oxygen weaning was unsupervised, which is obviously not ideal. The authors also found several statistically significant associations, and I've highlighted one in particular of interest, which demonstrates that the age at first visit to the pulmonary clinic was significantly associated with the ability to wean off of supplemental oxygen by 12 months of age. This is another interesting study that was conducted at 9 different US centers as an unmasked randomized controlled trial. And the authors were interested in determining whether use of recorded home oximetry data in the pediatric pulmonary outpatient clinic affected duration of home oxygen therapy in preterm infants. They found that the use of home oximetry data was associated with significantly reduced duration of supplemental oxygen. So the prior studies that we've touched on definitely demonstrate that following implementation of a multidisciplinary team does significantly improve outcomes in this patient population. And the last 2 studies demonstrate that pulmonary involvement with oxygen weaning does lead to improved outcomes in these measures as well. So Hannah and I, along with other members of the Norton Children's Pulmonary Neonatal and Cardiology divisions, are thus working to establish a multidisciplinary BPD clinic at our institution. So we've listed our main goals of the BPD team on this slide, including implementation of a discharge bundle with associated discharge criteria. We would like to improve transition from inpatient to outpatient care with involvement of pulmonology and cardiology if needed prior to discharge. And we hope to have improved clinical outcomes, improved healthcare utilization and patient satisfaction, specifically since many of these patients have significant comorbidities that require several different outpatient visits, so consolidation would certainly help with that. And we hope to also contribute to clinical research by examining outcomes before and after implementation. And also there certainly could be room for QI initiatives for this BPD multidisciplinary clinic. And so I won't go into great detail and read through everything, but this slide provides a more detailed list of possible potential benefits that could come from development of a multidisciplinary BPD clinic at our institution. So I realized that was a whirlwind of many different topics, but many of them were very important. And so just to drive home some of our take-home points, first, bronchopulmonary dysplasia is a very common complication of extreme prematurity. 2, the incidence of BPD is not decreasing despite advances in science and medical technology. 3rd, as with many pediatric disease states, further research is needed to support specific therapies and interventions. And lastly, and we want to really drive this point home, multidisciplinary care in patients with BPD leads to improved clinical outcomes, including decreased length of supplemental oxygen use and improved neurocognitive measures. So that is all we have as far as our talk. So we are happy to entertain any questions or comments at this time. I guess we can check to see if we have any comments in the bubble.
Well, of course, there's always going to be questions from me. One, I think you all did a great job of proving your take-home points. Intriguing to me, though, going way back to the beginning, one question, is there any correlation between retinopathy and prematurity with BPD? Because that sense of vascular development seems like it would correlate. And has anybody looked at maternal cytokines at the time of delivery, particularly wondering if there's a deficiency of IL-10, which would be an an anti-inflammatory cytokine. Since you're using steroids trying to aim at inflammation, IL-10 apparently can be manipulated with high-dose vitamin D to increase IL-10 levels. Are those things that have been looked at?
They have been. Typically, many of the major morbidities, such as ROP and BPD, tend to track together and probably have a similar basis of causation with inflammation, poor nutrition, premature developing systems, just like you pointed out. And so typically these babies with BPD also are going to be the ones that have more difficulty with ROP and other issues. Inflammation has been widely researched, and there are lots and lots of studies looking at different inflammatory markers and cytokines prenatally that lead to increased risk of BPD and brain injury and other of our morbidities. And there's definitely a link there. I think what's been lacking is a way to influence that. And so I have not read specifically about vitamin D and IL-10. We do supplement vitamin D as far as in our formulas and our vitamins in babies, but not with the purpose of specifically targeting that. So that would be really interesting to go back and look at.
There are old, at least mouse studies with high dose vitamin D and IL-10 in asthma models that have been impressive of increasing IL-10 levels.
Yes, thank you. Any other questions? We're happy to answer or talk about anything from our presentation today. All right, well, we appreciate you taking your time out of your morning to come listen to us. We're really excited about what's to come with caring for these babies together. And so thank you, and have a great day and rest of your weekend.
Yes, thank you so much. We're very excited about this partnership, and feel free to reach out to either one of us if you want to have any further discussions offline with us.
Thank you so much, Dr. Fisher and Dr. Stevens. Everybody have a great rest of your day.
Thank you.
Thank you.